We have discussed different types of pneumonia, how to empirically treat pneumonia, how to de-escalate to narrow definitive therapy. Now, let's develop a patient-specific plan for prevention of pneumonia. When it comes to the prevention of pneumonia, the older 2007 IDSA guidelines has several recommendations. Of course, influenza can lead to secondary bacterial pneumonia, so influenza vaccine is recommended, as well as pneumococcal vaccine, which I will discuss shortly. Now, for patients who are hospitalized, vaccination can actually be performed at discharge prior to patients going home. And of course, it can also happen in the outpatient setting. Smoking is a risk factor for pneumonia, so smoking cessation is very important in preventing community-acquired pneumonia. And those who continue to smoke, influenza and pneumococcal vaccination is really important for them. And of course, respiratory hygiene, including washing hands, is really important in preventing spread of germs. The new 2019 IDSA guidelines did not make any new recommendations for prevention of pneumonia. Before we talk about pneumococcal vaccine, it's important to distinguish between pneumococcal disease and meningococcal disease. When we say meningococcal disease, we are talking about meningococcal meningitis specifically, and this is caused by the organism Neisseria meningitidis, which is a gram-negative coccus. Now, there are 12 serogroups, so you will see this in the meningococcal vaccine, and there are different vaccines. For example, the MenACWY has 4 serogroups here, whereas MenB only has the B. Now, when we talk about pneumococcal disease, there are 2 diseases that this may be referring to. So pneumococcal meningitis and also pneumococcal pneumonia. And this is basically caused by Streptococcus pneumoniae, which is a gram-positive coccus. And there are 91 different serotypes. Now, we have 2 different pneumococcal vaccines. We have the Pneumovax 23 and we have Prevnar 13, which I will explain shortly. Now, it's important to distinguish between these two because there is some misconception out there. When we talk about meningococcal disease, people may refer to this as meningitis vaccine. So it is true that by taking meningococcal vaccine, you will basically prevent meningitis due to Neisseria meningitidis. And people may refer to pneumococcal vaccine as pneumonia vaccine. This is where the misconception comes in because Streptococcus pneumonia can cause pneumonia, but it can also cause meningitis. So by giving patients pneumococcal vaccine, not only are we trying to prevent pneumonia, but also we are trying to prevent meningitis. In fact, Streptococcus pneumoniae can cause several systemic infections, including non-bacteremic, such as pneumonia, and it can also cause bacteremia, which can also lead to meningitis. So meningitis, you can see smaller portion of these cases are meningitis, but the fatality rate is much higher in meningitis compared to other diseases caused by Streptococcus pneumonia. So really, in order to prevent meningitis, you need 2 vaccines. You need meningococcal vaccine and you need pneumococcal vaccine. Now, let's take a look at Pneumovax and Prevnar. So, Pneumovax has 23 different strains of strep pneumo, whereas Prevnar 13 has only 13. So, you might think that 23 is better than 13, but as it turns out, PPSV or pneumococcal polysaccharide vaccine is not as immunogenic. So, polysaccharides are basically carbohydrates that are relatively smaller macromolecules, and because they're small, we could put 23 different strains of strep pneumo in the vaccine. Now, they are not as immunogenic. In fact, in children younger than 2 years of age, because their immune system is not fully developed, we don't get any immune response. So it's actually not effective in younger than 2 years of age. Whereas PCV or pneumococcal conjugate vaccine, these 13 strains are conjugated to proteins. And proteins are larger macromolecules compared to carbohydrates. And that's why with current technology, we couldn't fit more than 13 different strains. But we get a strong immunogenic response from PCV, even in children younger than 2 years. So that's why it's actually very effective, and it's indicated for anybody 6 weeks or older. Now, the other thing is, because PPSV has low immunogenicity, it's actually in clinical trials, it actually has not been shown to prevent pneumonia, but it does prevent invasive pneumococcal disease like meningitis. Whereas PCV 13, because it has high immunogenicity, in clinical trials, it's actually been shown to prevent pneumonia itself, as well as invasive pneumococcal disease. Now let's take a look at who actually needs to get the pneumococcal vaccine. For a healthy person, meaning that they don't have any risk factors, prior to age 65 years, actually neither PCV13 nor PPSV23 is recommended. So they don't have any risk factors, so they don't need to get any pneumococcal vaccine. Now, by the time they turn age 65, because of the advanced age, they are at risk of getting these pneumococcal diseases. And prior to 2019, it was recommended that everybody age 65 get 1 dose of PCV13. However, since 2019, this recommendation changed to shared clinical decision making, meaning that this should be a discussion between the clinician and the patient to decide if the patient actually needs to get PCV13. And the reason for that is that we have had a program for pediatrics since the year 2000. So since the year 2000, we've been giving PCV7 to children. And then starting from 2010, we started to give PCV13 to all children younger than 6 years. And because of herd immunity, these 13 serotypes are less common in the population. So the benefit of PCV13 is no longer clear in these patients. So that's why it's a shared clinical decision making. Now, PPSV23 is recommended for everybody age 65 and older. So 1 dose is recommended because of those extra serotypes that you get from PPSV23. Now, if you do make the decision to give the patient PCV13, it is recommended to give the PCV13 first, and then 1 year later give the PPSV23. Now, if for some reason the patient initially didn't want PCV13 and they ended up getting PPSV23, and then later on they decided to get the PCV13, then there still needs to be at least 1 year between the two pneumococcal vaccines. So it's important to keep in mind that PCV13 and PPSV23 should not be co-administered. So they cannot be given on the same date. There has to be at least 1 year between them. Now, for immunocompetent persons with risk factors such as alcoholism, chronic heart disease, chronic liver disease, chronic lung disease, cigarette smoking, and diabetes, it is recommended that between the age of 19 and 64, that the patient receives 1 dose of PPSV23. And a dose of PCV13 is not recommended for this age group. And then when the patient turns 65, the PCV13 would be a shared clinical decision making, just like healthy persons. And it is recommended that these patients also get 1 dose of PPSV23 at age 65. Now, at this point, because these patients are indicated to receive 1 PPSV23 prior to 65, it's important to keep in mind that if you decide to give PCV13, it needs to be at least 1 year after PPSV23. And then the PPSV23 has to be at least 1 year after PCV13. But in addition, there has to be at least 5 years between the two PPSV23s. For example, if you give the first PPSV23 at age 64, once the patient turns 65, you actually have to wait to have 5 years after that one. So it will actually be at age 69 to get that last PPSV23. Now, for immunocompetent persons with CSF leak and cochlear implant, because they are at extra risk of getting meningitis, it is recommended that prior to age 65 to get 1 dose of PCV13, but in addition, they also need to get 1 dose of PPSV23. And then once they turn 65, if they have not received the PCV13 before, then they need to get a PCV13. If they did get the dose of PCV13 prior to 65, they no longer need to get a dose of PCV13, because once you get PCV13, because of the excellent immunogenicity, just one time is enough for lifetime. So that's why it would no longer be recommended. And then of course, just like everybody who turns 65, they need an extra dose of PPSV 23. And of course, because these patients are at increased risk of meningitis, when you give that initial dose of PCV13, you're not gonna wait 1 year to give the PPSV 23. So we're gonna do the minimum interval of 8 weeks and give the PPSV 23, and then between the two PPSVs, it has to be 5 years. Now, for immunocompromised persons, including those with asplenia, as well as those who have sickle cell disease, because sickle cell disease often leads to asplenia, those with cancer, chronic renal disease, HIV infection, immunodeficiency, and solid organ transplant, these patients are at very risk of getting pneumococcal disease. So it is recommended to get 1 dose of PCV13 prior to age 65. And then they need to get 2 doses of PPSV 23 prior to age 65. And then when they turn 65, they get 1 extra dose of PPSV 23, just like everybody else. And just in case they didn't get the PCV 13 prior to 65, they do need to get that once they turn 65. If they did get that PCV 13 prior to 65, then there's no need for an extra PCV 13. And of course, after PCV 13, there needs to be 8 weeks between PCV 13 and PPSV 23. Between the PPSVs has to be 5 years between each of them. Now, the CDC guidelines make a few points about patients who are 65 years and older with in regards with PCV 13. You know, one thing is clear that PCV 13 is safe and effective in these patients. You know, because of the pediatric program that we have, the PCV 13 type disease is actually much lower now than it used to be. However, keep in mind that as patients get older, they might be at increased risk, including if they have other risk factors such as chronic heart, lung, or liver disease, diabetes, or alcoholism. So these things can actually help you decide if the patient needs to get PCV 13 when you have those shared clinical decision-making discussions with your patients. And of course, the guidelines actually say that, you know, consider PCV 13 in persons residing in nursing homes or other long-term care facilities, as well as those residing in settings with low pediatric PCV 13 uptake, and those who are traveling to areas with no pediatric PCV 13 program. So these things should help you having those discussions with your patients when you decide if they need to get PCV 13 or not.